Stop. Good morning, everyone. My name is Annie Thomas, and I'm a faculty at Loyola University Chicago. And I assumed the position of assistant professor, and I'm a faculty since 9 years here at Loyola. So I'll be the moderator for the session, and you know the rules of the session, which I'll describe later. So in this session on women's health, presenters will explore culturally specific dance intervention to promote physical activity among Asian Indian adolescent girls, and also the socio-cultural issues that is affecting the pregnancy outcomes. And the third presenter will talk about women empowerment and reproductive health issues. And so we are going to have three sessions, and each presenters will get 15 minutes. And once when you have 2 minutes left to finish your presentation, I'll show this yellow card, okay? And then we will hold the discussions right after all 3 sessions are over, okay? And with that note, I want to welcome all the presenters and also the participants who is here. And the first presentation is going to be culturally specific dance intervention to promote physical activity among Asian Indian adolescent and college-going females. And the team of researchers are myself, Annie Thomas, and Georgia B. Connor, and Jeremy Franson, and Shweta Singh. So she is not going to present today, but we three are going to present today. To begin with, myself, I'm an assistant professor at Loyola University Chicago, and my research interests include type 2 diabetes risk assessment among Asian Indian adults and obesity prevention behaviors among Asian Indian adolescents. And my current research focus is to evaluate the feasibility of culturally specific physical activity intervention in adolescent and college-going females. And Georgia Connor, she is also assistant professor. She is the director of 4-year BSN program here in Loyola. And Georgia's overarching interest is health promotion and disease prevention and addressing health disparities among Asians. And her scholarship integrates the relationship between cumulative stress and psychosocial and biological factors within the context of culture. And her current research focuses on the impact of cumulative stress on the health of Filipino immigrant women and their daughters. And then we have Jeremy Franson, assistant professor with School of Nursing, but we have an exercise physiology department here in Loyola. And Dr. Franson's research focus is exercise physiology, including measurements of cardiovascular dynamics, hemodynamics, cardiorespiratory endurance, body composition, and exercise volume and intensity. So with that note, I want to tell you that I just want to talk about the famous historian who worked in the field of, who is a famous physician who said, eating alone will not keep man well, he must also do the exercise. So it's not a new belief that exercise could be considered medicine or part of medicine. So before the mainstream Western medicine and healthcare became more focused on sick care, or in other words, we say that the biomedical model, at the beginning of the 20th century, a major part of the physician's duties focused on preservation and promotion of health and prevention of disease. So our focus is preventative research, obesity research. So the strong emphasis on health rather than disease, and it dates back to one of the most prominent physicians, Hippocrates. Okay. So with that note, I invite Georgia Connor to begin the presentation.
Great. Thank you, Annie. Oh, I'm going to take the, I have to take the,
oh yeah,
the switch.
Yeah.
I think I can just leave this here, right? I don't have to clip that onto myself. Okay, great. Thank you, Annie, for a great introduction. And I'll go right into it. So, if you don't know this already, there is a rising trend in overweight and obesity, and it affects Americans of all ages. But what's most concerning, especially for this team, is you see the trend that's also rising among the youth, among the young children. And then we're also seeing, sorry, to move this closer, that this trend is rising among college students. You know about the freshman 15 if you haven't heard that. But then there's also studies that show that even with, on top of the freshman 15, there's an increase in percentage of overweight and obese college students. It went from 27.4% in 2006 to 29.2% in 2011. And so this trend is continuing to rise. And for those of you who are college students, we know that your schedules are packed, they're in flux, there's competing things like, homework, and other things that kind of get in the way of exercise, right? And we also know that there's this boom in technology, and the amount of time that children spend in front of the television and a computer, the video games, the phone, is increasing. And so this is taking over activities that otherwise, we would be doing outdoors. And sedentary behavior, in addition to having, to spending more time in front of the television set, studies have shown that doing that, being in front of the TV or in front of the video games, increases food consumption. And they're not eating apples and spinach when they're doing that. We're eating chips and things like that. And so we know there's strong evidence that demonstrates that precursors of adult cardiovascular disease begin at childhood, and that pediatric obesity strongly influences cardiovascular disease risk across the lifespan. And not only cardiovascular disease, but there are studies that show that sedentary behavior is linked to other health issues, including depression and anxiety and diabetes, right? And this is a particular concern for immigrant populations, because while there are a few studies, the studies that are out there show that they're at higher risk. You can see that high levels of physical inactivity and sedentary behaviors are reported among U.S. immigrant children and adolescents. So this is a huge concern. And it's a particular concern among girls. There's, again, studies that show, for example, that high school girls in all racial and ethnic groups are less active than high school boys. And you can see the comparison here, 38% of adolescent girls versus 24% of adolescent boys don't meet the national recommendations for moderate or vigorous physical activity. And that 48% report low levels of physical activity by the time they're in the 12th grade. So activity continues to decrease as they get older. Want to spend a little time on, because the focus of this is the transition period, and especially in adolescence, right? This is a huge transition period, but particularly for girls. There are a lot of changes that happen to the body composition. In addition to that, there's a reduction in insulin sensitivity and many psychological adjustments that occur, and all of this amplify the risk of becoming overweight. There's also less reliance on parental provision and choice of food. Kids go to high school, they get exposed to different types of foods, and oftentimes those are the cheeseburgers, the pizzas, and things like that, right? So that's that period of that transition that really impacts. In terms of sociocultural and economic factors among adolescents, and particularly adolescent South Asian girls, the few studies show that they have lower engagement in physical activity. And there are a lot of things like cultural priorities that are inherent among immigrant South Asians that make it difficult to routinely exercise. What's the emphasis? And this is with Filipinos as well. Academics, 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 right? And so that takes priority over a lot of things, including especially exercise. There's a lot of lack of awareness about the benefits of physical activity, and just these social restrictions, and even maybe some cultural norms or about exercising, for example, outdoors. That's for women is discouraged. And so the focus of this study is really on the adolescents, the children. This is an under-investigated subpopulation. Very little is known about what the barriers might be. And then also what they tend to do is put all Asians together in the studies that have existed. And I find this particularly difficult too, because it's the same thing with Filipinos. They put Filipinos are Asians, South Asians are Asians, and a lot of times there are so many differences in terms of what our actual barriers are. So that hence the importance and the significance of the study that has been designed. Jeremy's going to start talking now. We're going to transition. Speaking of transition.
The best place to put this, maybe like this. Hopefully that works. Okay, so as Georgia was saying, we really want to first determine what the activity level is amongst Asian Indian adolescent females. So Dr. Thomas did this initial pilot study just to determine, their physical activity level. I mean, despite the evidence that of the benefits, we do know that they have lower engagement in physical activity. So that really, identifying that is really the first step to move forward then to looking at this population. So the significance of our study is, aimed at preventing, increases in weight and percent body fat gain early on. So really the significance, I'd say overall, is just catch them early, right? As you catch adolescents in their behaviors, their lifestyle choices, what they eat, how much physical activity they do. If that can, start early on in the lifespan, that's going to carry through their lifespan and probably into the next generation and how that they raise their kids with the different types of diet and activity that they do. So we really feel that it's important then to, to identify these populations and then employ these lifestyle interventions early on to put them on a different trajectory than we currently see with a lot of adolescents in general overall. Well, so we're going to look at now dance as our physical activity. Why dance? Well, number one, it is a moderate intensity physical activity. When we think of our individuals getting enough physical activity, we really have to think in terms of minutes per day, 60 minutes per day, 6 or 7 days a week. That's the recommended. So an hour a day. Or if you're thinking counting steps, that's 13,500 steps would be considered moderate, vigorous, 60 minutes. Or 3 days a week at a higher intensity, very vigorous activity for about 20 or 30 minutes. But that, that can kind of turn off a lot of people when you hear that, very intense physical activity, multiple days a week. But that's why dance is a great intervention, because you get the increase in heart rate, you get the stimulus for adaptation, and it can be fun, and it promotes social interaction. We do know that cultural specific dance has been effective at reducing heart disease risk factors in other populations, in Latinos and African American school-age children and women. So really wanted then to move forward into Asian adolescents and women and look at the benefits. But we do know with exercise, and this goes with other types of exercise too, that dance can improve flexibility, reduce stress, boost memory, manages weight, increases balance, flexibility. Also, like other group exercise interventions, it promotes, it can increase adherence because it's a social network that you form, and you can have fun and make friends and things like that. So it's a great way to introduce physical activity. What we're looking at specifically now is Bollywood dance. So that's a cultural specific, a moderate intense physical activity. It's like a free form style of dancing, incorporating similar moves to hip hop, salsa, and belly dancing. So it's fast moving, fun, expressive, energetic, gets the heart rate up, and it's a good form of physical activity. When they looked at, one study did look at South Asian women's belief about physical activity and dancing as a form of exercise. This was done in Canada. And in that study, they found that women found that dancing would be the most appealing form of activity, was what their consensus was. And if they had access to it, a women's only dance group, led by a woman, and they had childcare services, that would increase adherence. Because I think the biggest thing with this population, like most populations, is motivation and time, right? Those are usually the perceived barriers. So, but they did think that dance would be a great form of activity, looking at the options that seemed to be the most appealing in this group in Canada. So, but the effectiveness now in Bollywood dance has not been studied. And so that's the purpose of our research, is to look at Bollywood dance as an intervention for Asian women, Asian Indian women. So other research now, once again, looked at other populations, blacks, whites, Latin American youth, but not Asian Indian adolescent and college-going females. So this group has not been studied. So we anticipate that the Bollywood dance intervention will promote physical activity. It'll increase adherence and promote it amongst Asian Indian female adolescents. And hopefully then also we expect that it will reduce cardiovascular risk measurements. So we're looking at cardiovascular risk measurements, engagement in physical activity, perceived physical health and mental well-being, and then also just the feasibility of being able to put the group together, get them to come to the dance intervention over the course of the study. So the data collection was performed in Lombard, Illinois. When the participants came in, we got the background history. We collected anthropometric measurements, meaning body mass index, BMI, percent body fat, waist circumference, blood pressure, heart rate, physical activity. Also then, we also measured perceived barriers and benefits to physical activity, along with physical activity self-efficacy, or how much they believe that it's going to be beneficial for them, physical activity attitude and perceived control, physical self-perception, dance enjoyment and intent to change behavior and attitude, and then finally a dance satisfaction survey. So we wanted to capture some physiologic, mental, and participation kind of data with our group. Okay. All right, I'm going to pass it over to Dr. Thomas.
Okay, so Jeremy spoke about various measures that we are taking, but in addition to it, we have the intervention. For the interventions, the participants meet for 60 minutes right after the church session is over. So those 60 minutes of Bollywood dance session is, that is directed by a skilled Bollywood dance trainer, and we have the session for 6 weeks. But you might think that during those 6 weeks time period, during that weekday period, what are they going to do? So we provided them with the Bollywood dance DVD. This DVD is from the Dunia. So that is one of the famous dance troupe based in New York. So we had those DVD purchased, and then we handed over to the participants, and the participants, some of their parents also do with them, these kind of exercises. It's fun. So they do it, and on a weekly basis, they are reminded to perform these exercises, and the research assistant that have been hired in our project, she contacts the participants on a weekly basis to perform these, the dance sessions using this DVD at home. So, so this is one of the pictures that I pulled out from the Dunia website. So this is how it looks like, and we have awesome trainers, and so they do the workout dance session. All right. So the data collection period, it's happening in 2 phases, 2 sessions. The session 1 is already completed with 15 participants, and that was over. The first session started in March 19 with 15 participants, and the second session began on October 16. So tomorrow is going to be our 3rd session. Okay. All right. So I'll show you this dance exercise DVD on how.
Today we have Janani Talaka, master trainer for Bombay Gym, here to take us through a 10-minute Bollywood dance fitness workout. Let's get on the dance floor. We're going to start with 2 cardio routines today. The first is based on Bollywood hip-hop style. The second is based on Bollywood Bhangra style. I know Anna's got her Bollywood groove on. Oh yeah. I know Shobna's got her Bollywood groove on. You got yours? Let's get going. All right. I'm going to begin by breaking down some of the moves for you before we get right into the routines. The first track, like I said, is Bollywood hip-hop. Get that whole feel going. We're going to begin with a cross step. Take your right leg, cross it across, and out. We have arms to this. We keep your hands fisted right here. Arms are going to go the opposite direction of the leg. Let's try this together. Okay. 1, 2, 3, 4. Step out into a second. Drop it low. Take the right hand, curl it up. 5, 6, 7, 8. Good. Same thing. Left leg. 1, 2, 3. Left hand curl. 5, 6, 7, 8. Nice. You can add that whole feel to it. Yeah. Yeah. Just put in your natural style. Second step. Take the left leg, cross it back. Right hand comes out. This is a jazz hand. All 5 fingers open. It's 1, 2, forward. Open out that leg. 3, 4. Other side. 5, 6, 7. Let's do it one more time. You can turn the head, look towards the arm if you want, and bring it back forward. 5, 6, 7, 8. Simple? Yep. That was an easy one. All right. Chorus. Every time the chorus comes in, we have stomp forward. 2 stomps forward, 2 stomps back, and just a low step in place. Leaning forward with the right leg. When you go forward, the jazz hand, pulling back. 1, 2. When you step back, take a fist, start with the arms crossed, open out. 3, 4. When you crump, bring right here, fist in front of you, angle them a bit, push. 5, 6, 7, 8. Should we put the hands and legs together? Okay. Yep. All right, let's go. 1, 2, back, 3, and 4. In place. 6, 7. One more time. Take it up. 2 and back. 4, crump. 5 and 6 and 7 and 8. Good. Very nice. Just a couple more steps, right? Walk forward. Keep your hands right here, fingers loose like you're calling somebody. In fact, that's what the lyrics say. Dance with me. So, inviting all your friends to dance with you. Start with the right leg crossing forward. Angle your body to the left diagonal. Hands keep calling. It's like a 2-step. 1 and 2. 3 and 4. 5 and 6. 7 and 8. Walk it back. Take the arms up. 3. Circle the hips. 5, 6, 7 and 8. You got that one down? Whoa. All right. One last step to go. Okay. Angle your body to the right diagonal. It's a body wave. So lead with the head, shoulders. Everything else follows. 1 and 2. Back. 3 and 4. Walk. 5, 6, 7, 8. Pop that shoulder as you go. 1 and 2. 3 and 4. Take left, right, left, and right. We do this one more time. That's all the moves you have for the first track. All right, let's try it out. You guys are ready? We are. Start in the second position. Feet out. Hands down. Take the right hand up. And left. Curl the wrist up. 4 curls. Lunge and open out. Right hand, right hand up. And left. Wrist curls up. Open. 5, 6. Walking around your spot. 4 count. Cross right. Wrist curl. Left leg cross. Back curl. Right leg again. Cross. Cross back, jazz hand down, forward, up side, repeat. Stop forward, pull back, fist, hook, hit, take it up, go. Bring that energy up, take it up, and hook. One more, last time.
So I know that it is fun to watch, but I have to stop it. Okay. Okay. So. Okay. So. And my trainers are associated with this company. Okay, so I have 2 male trainers who comes and teaches my participants. So what are my goals out of this research? So this pilot study will inform, what is the feasibility of conducting Bollywood dance intervention in a specific setting and move from the church setting to the other community setting, and also to explore how the culturally and gender-specific opportunities for physical activity will enable girls of Asian Indian ethnicity to begin with, but to expand further to South Asian community to make positive choices and engage in health promoting behaviors. And the future direction is, I just don't want to stop it with this preliminary studies, but when you look into various community centers, I see that we don't have much of community centers where we can attract more of our adults and girls, or maybe the females, to come and do these kind of exercises and other forms of services. So my future goal is to come up with, in collaboration with my researchers, to promote sustainable health promotion behaviors. For that we need funding. Okay, so on the basis of what preliminary finding that I'm going to get, and we will be writing more, the proposals to avail grants. So that's it for today. So let's go with the theme, dance, 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 right? Okay, so that's all. And these are some of the references, and thank you so much for being wonderful attendees for this presentation. Okay. All right, so let's move on to our next presenters. Are you ready? Okay. Many socio-cultural factors becomes a barrier in achieving quality health outcomes, and these socio-cultural factors include customs, lifestyles, values, and so on. And when you look into various subcategories of those such socio-cultural factors, we have religion, economic status, class, time, gender roles, language, and family. All those influences in achieving health outcomes. So how these factors affect achieving the pregnancy health outcomes, and that is going to be the focus of their presentation. And we have 2 wonderful presenters, Revati Narvane. She's from Texas A&M University, and Revati is a Loyola University Chicago alumni, right? 2015. And then she is currently a second-year MPH student of epidemiology at Texas A&M University, and her work in healthcare services with refugee populations and disadvantaged group has led her to explore behavioral factors that are associated with maintaining a healthy community. And we have gorgeous Nishika Ramchandani, and she is from Boston University. Okay, and Nishika also is a Loyola alum. Oh, how wonderful it is to see you all. Okay, and she is currently a first-year health policy MPH student at Boston University, and her work is with the disadvantaged population, growing up with strong sense of, and she grew up with strong sense of cultural identity, and she is a first generation Indian woman, and how all these factors gave inspiration to Nishika to pursue her public health focus, studying pregnancy outcomes. So we welcome you both to present this topic. Are you going to be first? She's going to go first. Do you want to introduce yourself first? Yeah.
Hi everyone, I'm Revati Naravne. I am a second-year MPH student, like she said, and so our presentation today is just going to be a proposal presentation. We haven't done actual research yet, but what we're here for, we've done preliminary literature review, and so we want to look for mentors or funding opportunities that we can possibly find through this network that we're creating here. So bear with us. Our presentation is going to be short because it's only, it's based on preliminary literature review. But yeah, both of us went to school here. We were roommates, and we both share this passion for studying unhealthy populations, I guess, and just disparities in populations that we can hopefully come up with an intervention for. And when it comes to women's health, again, we're both women. We were both raised to be strong, independent ladies in college, and so we want to make sure that everyone gets that opportunity, whether they're an immigrant here or a citizen. So we wanted to.
So my name is Nishika. I went to school here. I just graduated in May. Currently, I'm studying health policy at BU in their School of Public Health. So looking from the higher policy side, this is something that I was interested in, just to see what kind of interventions we can put into place that kind of already go with, we already know how tough women's health is as an American citizen. So just looking further into it. Yeah. So healthy pregnancy outcomes are defined by 3 things. They're defined by the infant birth weight. You want to reduce preterm births, and you want to reduce neonatal deaths, basically. But all the research that we do have so far is this broad Asian umbrella category. There's no specific research on South Asian women specifically, and we know that there's so many cultural factors that affect pregnancy. We wanted to take a further look into see how those outcomes are affected. So in 1990, almost 200 out of 1,000 women gave birth between the ages of 20 to 24. And in 2016, women are predominantly giving birth at the ages of 25 and 29, which is already putting women at a higher risk. And especially we know with South Asians and that focus on academia, more and more ladies are going through more and more school, which puts you at giving birth later and later, which is, again, not the healthiest time to have a baby. So, again, there's not that much data on specifically South Asian women. There's this huge umbrella category of Asians that involves different levels, and you're looking at different populations, first-generation immigrants, citizens, and even data from just different countries. So trying to collaborate all that in and seeing what we can do with it. So what factors do we think would be associated with pregnancy outcomes in first-generation immigrants is the way that we're raising our girls generally. There are studies that show South Asian girls don't get the best sex education as it is, which can lead to complications later in pregnancy, getting pregnant, and having healthy pregnancies. And then we also know that South Asians are already predisposed to higher rates of cardiovascular disease, which can impact high-risk pregnancies. And then we also know the mass cultural belief system that goes into being pregnant. It's not just the woman getting pregnant, it's this entire family having a baby, what the mother-in-law wants you to eat, what your mom wants you to eat, what you think you should eat compared to what your doctor is telling you. So there's all these factors that go into play. And then also the huge impact of the gender role and how your husband views you when you're pregnant, how your family views you when you're pregnant, what you're allowed to do, what you're not allowed to do. And then moving from this huge emotional support connection from in India, where you have your mother-in-law next door, your family is right there, to this very nuclear household in the United States, where it's just you and your husband, and there's not that huge background of emotional support.
All right. Like she mentioned, we have, whenever I go back to India, there's always, whenever I see a woman, she's so supported by not only neighbors and the community, but also their family, especially when she's pregnant. There's always family members taking care of you. There's always someone telling you what to do, what not to do, and stuff like that. And then you see very new immigrant women here. If they get pregnant, they're kind of with their husband, and that's about it. And if your husband is working, all the time, you're kind of alone, and that definitely puts, like a strain on you, not just physically, but mentally, socially. And so that's why we set out to see if there was any research done on this before. And we've created a very preliminary literature review so far. We do want to further research this, obviously. But I think when we go forward with this, we want to see if this specific question has been studied before. about the social cultural factors that are different between India and America when it comes to South Asian women getting pregnant specifically. And then just looking at the study on South Asian immigrant women's lifestyle, especially in immigrants, you have diet changes, you have physical activity changes, because in India, if you want to go to a store, you're probably walking to the store, and that again is a higher rate of physical activity than here when you just go sit on a bus or your husband drives you to the grocery store. Again, that affects your physical activity there as well. And so I think when it comes to methods, like we want to go further with this, figure out how we can survey women, how we can build those strong connections with organizations that actually do serve pregnant South Asian women, so that we can further research this as well. So we hypothesize, just because of the conversations that we've had between each other, with other South Asians and even pregnant women, that various social, cultural, and behavioral factors, depending on those, that South Asian immigrant women will have poorer pregnancy outcomes than native South Asian women or their South Asian Americans or their South Asian counterparts in India. So resources that we need, since this is a proposal presentation, if any of you know mentors that would be interested in something like this, or if you guys know of any funding opportunities, we're definitely willing to get into that grant writing stage and actually research this and submit proposals, and also again build those strong connections with organizations that actually do study or serve these kind of women. So yeah, that was our presentation real quick.
Thank you. I hope you will get funding opportunities. Okay. All right, so we live in a world where we witness gender and sexuality related issues, and we often witness gender inequality. So the proverb says, more healthy the women are, more healthy the planet will be, right? So we have a presenter who is going to talk about women empowerment and reproductive health. And Shamsun Nahar, she traveled with her husband, and she's coming from University of Texas at Arlington. And Shamsun is a Bangladeshi PhD student, okay, and who believes in proper education and implication of policies can help to reduce the women's vulnerability in developing countries. And she has a master's degree on sociology and social work, and her research interests are women's reproductive health, gender-based discrimination, and decision-making and international social work. So we welcome you.
Hello, everybody. So she already mentioned I'm Shamsun Nahar, and I'm a second-year PhD student in University of Texas at Arlington. And she already mentioned my research interest in women reproductive health and international social work and gender-based discrimination. So today I'll talk about women's empowerment and reproductive health in developing countries. And for this study, I applied a qualitative interpretive metasynthesis, QIMS. So I took this picture, of course, from online, and it shows this pregnant woman is having treatment during her pregnancy. But it's not the true or real scenario for most of the women who lives in rural area in developing countries. According to World Health Organization, every day 830 women die related to pregnancy-related causes or during their childbirth. So, and among them, like 99% women, they are in developing countries. So that means it's a huge problem for developing countries' population. And several studies, they found that there are 3 reasons for these deaths. The first one is delay in receiving adequate and appropriate care, and second one is delay in making the decision to seek health care, and third one is delay in reaching to health center or hospital. And so that means these all causes are related to lack of women empowerment, and that prevents them to achieve and enjoy their health rights. So my study purpose, understand the impact of lack of women's empowerment on women's reproductive health, and second one is understand the essence of cultural competencies in women's empowerment and reproductive health through South Asia and Africa. So I already mentioned I have used QIMS method. So of course you are curious to know what is QIMS method. So it's a method which synthesizes a group of qualitative studies on a related topic to enhance the knowledge of a specific phenomenon and create a new, deeper and broader understanding of that phenomenon. So it's like qualitative research, basic qualitative research, and in this research also the researcher is an instrument, and here also researchers' credibility and triangulation of resources, methods, and theories are very important to establish the validity and reliability. And so what steps we follow for conducting QIMS research? The first, like regular research, you have to define your problem area, and then you have to come up with several questions, of course. And then after that, you have to identify sample of qualitative studies to be synthesized. So how you will collect your sample? So in what I did, I used secondary data. So like I used as a search engine, Google Scholar, and academic search complete to search my qualitative study regarding my topic, and I found like 178, I think, has come up, and then among them I reviewed and I chosen 6 qualitative studies regarding women and women reproductive health and empowerment. So and those 6 studies I found 367 individuals who are conducted for the interview. And after that, you have to extracting original themes from each studies and then synthesizing original themes across studies, applying a constant comparative method to evolve an inductive theory. So in my studies, I found these 6 themes. So the first one is power of husband on contraceptive use, pregnancy, family size, and health care seeking. So I found that and in Asia and Africa, both regions, husbands are the decision maker who will give you decision on women to take, she will receive contraceptive, she will use contraceptive or not, or like sometimes she can be abused or beaten if she wants to use contraceptive. And like sometimes they force to women to have unprotected sex. So, and Second one is power of mother-in-law on healthcare setting. And for this, I also found that in both regions, mother-in-law has huge power on women's healthcare decisions. Like they need to get permission from mother-in-law, or they need to convince her to go to the health center or take healthcare. And a victim of physical and sexual violence. So in this case, I found mostly in Asian regions, women are mostly victim of physical and sexual violence than African regions. And sometimes husband and husband's family members, they beat them or abuse them. And yeah. And fourth one in gender preference and pregnancy, and especially in Asia, India, gender preference is a huge problem. And if women give birth to a female child, they are maybe neglected or abused or forced to take another child, like that. So financial dependency, and both regions, married women are mostly dependent on their husband or any other family members. So I think it's one of the reasons why they don't leave their husband, even they are victim for domestic violence or any other kind of violence. So it's a huge problem in both regions. And dissatisfaction with contraceptives. So I found this only on African regions. As I considered it as a negative case. So, but it also a reason for like infertility and risk for women's health. So from this discussion, I found that for all of these causes related to women's empowerment, if they are empowered, they can overcome these types of problems and they can enjoy their health rights globally. And so I proposed some implications. Of course, we need to overcome this problem. Like local government can apply like sex and reproductive health education policies. Yeah, already every country has some policies, but most of the case that are not implemented well. So, and there are maybe need more policies regarding that. And promotion of health illiteracy, like most of the women don't know their body, how they work or what they need for their reproductive health. They just become pregnant, but they don't have any education on that. And interventions are needed, of course, regarding women's decision-making autonomy and negotiation capacity on family planning. And I think social worker can play a huge role on this sector. They can educate women, they can advocate for more training, and they can force to create new policy. And so my limitations is in qualitative study, researcher is the main instrument, so there can be one limitation is researcher bias. Researcher can be biased. Maybe she is interested, maybe I am more interested in this topic. So, but it is possible to reduce the biasness. And sample size, so I just selected 6 studies. So it's a small sample size, and it's like I mentioned developing countries, but developing countries population is huge population. So I think more sample size is needed for more reliable results. And yeah. Thank you.
Thank you, Shamsen. I see that there are lots of studies being done qualitatively, and the qualitative studies, through metasynthesis and meta-analysis, is going to contribute to evidence-based practice. And many researchers, they do mixed methods these days, integrating both quantitative and qualitative research, because our focus is evidence-based practice. So with that note, we have finished with all the sessions and we are on time. And I invite all the presenters to come forward, and then now we will have a question answer session. Okay? And the rule is that even the presenters from each presentation can ask questions to other groups, since our numbers are kind of a bit limited. Okay?
I actually have a question for the two of you. What are you thinking of your design, your method?
I think we're thinking of doing a quantitative method at this point, just because I think we can come up with certain factors like diet or like emotional support, or and based on the presentations that we've seen here and even yesterday, there was a presentation yesterday, I think, about how woman empowerment was affecting domestic violence, and that was really cool to see, because we could see that he broke down certain factors of even woman empowerment. So we're trying to see if we can do a quantitative study and then do a regression analysis.
So you'd have to put together, based on the literature or the studies that have been done, and identify that and develop your own questionnaire. I ask because my dissertation study, I was prepared to, I did all this, I took so many statistics courses, and I thought I was going to do a quantitative study.
Yeah.
And what I found, because I have a similar issue with the Filipino immigrant women, and I was specifically looking at nurses and their occupational stress and their adaptation experiences, and I could not find a tool. I couldn't find, and the tools that were out there that were being used, they weren't valid for this population. It was really not tapping into what I thought was their issue. So it's going to show that they had no stress.
Right.
And I really fought it, because I felt like I wasn't going to be able to, I wasn't prepared to do qualitative study. And my mentors had said to me, you're doing all this work, everything that you did, your preliminary work shows you that the state of the science right now is that you need to do more qualitative work, and from that build your quantitative work. I just wanted to kind of put that into your mind, because this isn't your life work, right? And I think my own research can show you that, where I started with qualitative. I couldn't be happier that I did that, because it showed where the needs are, and now I have moved into this more quantitative, and in fact looking at physiological measures. So not only the questionnaires, but I'm looking at telomeres and telomerase and inflammatory markers, and putting all of this together to kind of create that picture of the impact of stress on the development and risk for developing diseases. So just kind of think about that as you're doing this, because there's nothing wrong with qualitative study if that is where the state of the science is, and we just don't have the data.
And I'm sure we'll find out that it might be even better to do a qualitative as we do more research on this. This is just, so we found out about this conference like last minute, and we've been like talking about it, and we wanted to do something, and so we were like, okay, let's do our preliminary research and see what we find so far, so that we can have something to present and see if there's people out there that are interested. And there are, like, even at this conference, there's so many people interested in the same things that we are. So,
And in terms of funding too, it might be less expensive for you to do just some interviews yourselves, and then as you're doing that, then you can continue to write for funding. So just
thank you.
just a little mentoring.
We'll take whatever we can get. So thank you.
Yeah, just to follow up with Georgie's question, I was going to ask you, like, based on your preliminary research, if you have any lessons or hypotheses, depending on the research that as so far, I don't know if you.
I think the thing that we found most interesting was there was a lot of studies on diet, and like growing up South Asian, we know that there's like always that like you're sick, oh like I'll leave food, like
think that's
I
just.
would love to read that. The stories that come out of that.
You have a question?
Yeah, this question is kind of directed toward Shanson.
Yeah.
You know, when people think of countries, and you kind of alluded to it a little bit at the end, I think, with your limited sample. When they think about countries, they'll say England, France, Germany, Poland, Africa. And Africa is not a country, it's a continent.
Yeah. I know.
And, but that's how it's compared. So I was just wondering, in your sample, how you, did you just do countries, just a few countries, or what? Because you call it African.
Yeah, it's a good question. Yeah, I forget to give this. In here, you will find which countries I have chosen for my study. So it's Pakistan, India, Nepal, and from African countries it's Tanzania, Burkina Faso, and Uganda. So I think this study result will help you. And this is how a QMS method works. And this part. And if you are interested.
Okay, thank you.
I apologize.
Any more questions? Okay, go ahead.
I have a question. So is your guys' focus group immigrants that have just come, or is it like first generation, or? I think we wanted to compare like across the board. And you have like South Asians in India, you have people that grew up here,
Yeah.
and then you have immigrants.
South Asians, yeah.
Yeah.
So I think comparing all three groups would be something that would be,
Yeah, because I bet it varies.
yeah.
Like as a first generation, we probably have totally different experiences than our parents.
Yeah.
Do a culturation measure to
Yeah.
get to that.
And any more questions? You have? Okay.
So I'm an outsider.
Can you
Oh, no.
Yes, please help us.
It's just something like I would like to recommend from my perspective. I am also doing my part-time PhD in computer science with big data and data analysis. So I was just curious about the talks, and something just popped out. Like your presentation was really interesting, like incorporating dance and those stuff, and you are thinking about the pregnancy outcomes or the adverse effects. So just these ideas popped up in my mind. Like, is there any studies there, like how this dance or activities can help overcome this pregnancy barriers?
Oh, that would be interesting to study.
Suggesting.
Yeah.
For example, what I know from my personal experience, like my friends or families in Asian countries or like more over the world, like I mean, people are getting like more technology oriented, and the natural childbirth rate is decreasing in Asian countries. As I don't know about the US population yet. So there, most of the time, the C-section or cesarean is suggested. So what will be the implication of incorporating dance habits?
Yeah, I think that would be
women's
wonderful
life?
as you move
So
from.
that, you know,
Yeah, as
they
you move.
toward the-
Yeah, that's a great idea. You know, once when you have that preliminary databases in your research and moving along in your research career trajectory, after you do those exploratory studies and you'll have a good data bank, and you know, then you can think about various intervention measures to promote pregnancy outcomes for the benefit of better quality life. Yeah.
Right.
Yeah.
Yeah.
We want to jump.
Yeah.
Yeah, 10.
Yeah, that's why we're not even thinking about intervention
Yeah.
right now, because again, we don't know the status. Right?
Yeah. So review of literature is the best way to begin with. Yeah. So I think then moving along, you'll have good base to build on. Yeah. Okay. So with that, we need to finish all our questions and answer session. So I'm seeing that we have a great connectedness when it comes to the socio-cultural factors impacting the health outcomes, whether it is physical activity related outcomes, reproductive health outcomes, and also we have the pregnancy health outcomes, right? And also from the methodological perspective, I saw the quasi experimental intervention, and in yours you're beginning to have that, the further level. And one of the great way of generating evidence where we don't have much of evidence through metasynthesis or meta-analysis, and you are doing that. So probably I think we can have more sample size, since you said you have only 6 samples in your studies to come up with those themes, and then have the evidence-based outcomes with that. So with that, I think we'll have more of the quality data with you to influence the practice outcomes. So all of the methodologies, I think our focus should be to take these P's and then translate those evidence into practice, right? So the translational research should be our focus in order to benefit the individuals and communities at large, not within the United States, but across the globe. So thank you so much for the wonderful presentation, all the attendees. And now we have to go to other presentation, which starts at 10:30. Thank you.